Welcome everyone to Clinical Pharmacology Grand Rounds. Today we're going to move beyond the textbook and tackle a condition you are going to see constantly on the wards, Irritable Bowel Syndrome.
So, let's make this real. This isn't just about pathophysiology, it's about your future patients, people like Debbie, whose lives are just profoundly affected by this. Okay, let's dive in.
You know, when you first encounter a patient like Debbie, the symptoms can feel, well, chaotic. Your first job is to deconstruct all that into a clear clinical picture.
IBS really boils down to three core features. You've got chronic abdominal pain, altered bowel habits, and then associated symptoms like bloating. But, and this is absolutely crucial, you have to recognize the red flags that scream, this is not IBS. Things like waking up at night with diarrhea, seeing blood in the stool, or unexplained weight loss, those are alarm bells that mean you need to dig a whole lot deeper.
Subjective symptoms are the start, for sure, but for a confident diagnosis, we need objective criteria.
And for that, we use the Rome-4 criteria. As you can see, Debbie's history of recurrent pain, how it's related to defecation, and the change in her stool frequency and form, well, it clearly meets all the diagnostic requirements. This is how we do it.
But getting the diagnosis is just the first step. Treatment is guided by the subtype, and for that, it's all about the stool. The Bristol Stool Form Scale is your objective tool for this. It takes the guesswork out of it.
So based on Debbie's report of frequent loose stools, which are consistent with a type 6 or 7 on the scale, we can confidently diagnose her with IBS with predominant diarrhea, or IBS-D. And here's the crucial point. We now have a specific target for therapy.
All right, let's move on and see how this builds our treatment plan for Debbie. For IBS-D, our goal is pretty simple. We want to slow transit time and reduce that awful urgency.
We always follow a stepwise approach. We start with accessible agents like loperamide, and then we progress to more specialized therapies for severe, refractory cases like Debbie's. And that brings us to allosetron.
Allosetron is a powerful tool because it directly targets the serotonin pathway in the gut. It works by blocking these 5-HT3 receptors to decrease motility and those visceral pain signals. But, and this is a big but, this potency comes with a significant risk.
We're talking about a risk of ischemic colitis, and it's approximately one case for every 1,000 patient years of use. While that may sound rare, you have to remember that it is potentially life-threatening.
And this slide brilliantly illustrates why you must remember this black box warning. Allosetron is restricted to women with severe IBS-D who have failed other therapies, and it must be stopped immediately if constipation develops. Period.
Okay, to really solidify your understanding, let's contrast Debbie's case with the opposite challenge, IBS with constipation, or IBS-C.
Here, the therapeutic goal is the complete opposite. We are not trying to slow things down at all. We need to increase fluid and motility.
And the treatment pathway reflects this. We'll start with osmotic laxatives, and if those don't work, we escalate to a class of drugs called secretagogues, which actively increase intestinal fluid.
So for your board exams, and just for rational prescribing in general, you really need to know how these drugs work.
Lubiprostone works by directly activating chloride channels on the intestinal surface. Chloride flows out, and as we know, water passively follows, which softens the stool and increases motility.
Now, what's really interesting about this slide is that linaclotide uses a different pathway. It activates the GCC receptor, which ultimately uses the CFTR channel. Yep, the same one implicated in cystic fibrosis to get a similar secretory effect. So, as you prepare to step onto the wards, how do you translate all of this into excellent patient care? Here is your 6-step framework. It starts with listening, and it ends with prioritizing safety. This is your roadmap for every single patient with IBS.
Okay, these are the absolute must-know points. Validate the patient's experience, use the Bristol scale, simplify the goal for C versus D, and never, ever forget the allosetron warning.
I'll leave you with this question, because the ultimate goal isn't just to manage symptoms, it's to restore quality of life. Thank you.